Health Alert is brought to you by OU Physicians in Tulsa. Hello, welcome to Health Alert. I'm Pam Butler. Today we're going to talk about the disease model of addiction, and joining me is Brad Collins. He is the Program Director of the Adolescent Substance Abuse Treatment Center at Palmer Continuum of Care. Welcome to the program.
Thank you, Pam.
Now, you were here before where we talked about substance abuse issues and some specifics about substances.
Yes.
Today we're going to talk about the disease model, sort of what makes us prone to these kinds of addictions, I guess, for lack of a better way to put it. Before we start, though, for people that didn't see the previous show, behind your name, you've got these letters. Tell us what they mean.
MHR is a Master of Human Relations. It's a counseling degree that I achieved at the University of Oklahoma. And LADC is a licensed alcohol and other drug counselor, and that's a licensure that I procured from the state of Oklahoma with my higher education credentials and other training to become an addiction-specific counselor. Okay,
now with Palmer, I do want to also, for people that didn't see the previous program, sort of highlight what is Palmer Continuum of Care and what is the philosophy of Palmer, especially Continuum of Care. Explain that for us.
Well, a Continuum of Care, why we adopted that name to go behind Palmer, which has historical relevance for us, is because in the treatment of addiction, in the treatment of substance abuse, it's best practices to treat someone at the level at which they present with their problem, and then either step them down when they start to achieve some progress to a lesser intense level of care, or step them up to a more intense level of care if they're not achieving the progress that they should be over any given time span.
Okay, now with Palmer, do you look at group therapy, individual therapy? How does that work? Because as we know, substance abuse and those things affects the entire family or the entire community. How do you focus your therapy?
Well, all of our treatment programs are customized to fit a specific client or a specific patient, if you will, because addiction is a disease. But we have clients who come to our facilities for treatment of substance abuse issues that they haven't progressed yet into that addiction piece.
Okay. Okay. Now with this, do you see all ages? I mean, you are the program director of the adolescent area. Do you see kids younger than adolescents? Is it all the way up to adulthood? At the age is limitless? What's the range?
Our dotted line cutoff is 12 years old.
Okay.
And we see mostly 14 to 17-year-olds. That's the predominant population that come to our facility for services at the Adolescent Treatment Center. But as we spoke about before, we have another facility on Mohawk Boulevard here in Tulsa, the Tulsa Women and Children's Center, where we treat women with addictions and their dependents and or women who are pregnant with addiction issues.
Okay.
So yes, we run the entire spectrum. We treat, of course, on the female side, women with addictions, their children, and we treat not only the adolescents for substance abuse and or addiction issues at Palmer Adolescent Outpatient Treatment, but we also include the family members because, once again, there are environmental issues, there are social issues, there are so many issues that are involved, but addiction is a family disease, and substance abuse does touch every member of the family and every even external and peripheral member.
Okay. Now I do want to get out there because you mentioned that in the last show, and I think that that's extremely important for people to know in terms of access. And do you have to have a certain amount of money? Is there a certain copay that's due? If you don't have insurance, I mean, we always think about those issues that can kind of prevent us from getting the help we need. At Palmer, what about the services there in terms of the charge?
Well, the charges for the actual recipients and the family members of the recipients of our services is nothing. We are fortunate to be contracted by the state of Oklahoma, reimbursed by them for many of our services. We also have Medicaid contract whereby we're reimbursed for many of those services. We are a United Way partner agency, so we have that benefit of being very nicely funded by the United Way, as well as some private donors who contribute good deals of money to us because they believe in what we do and they see the results that we get.
Okay, let me ask this question. I didn't ask you on the previous show about this, but I do want to ask this question now.
Sure.
Sometimes people say, I want to come in for treatment. I know I have a problem, but I don't want anybody to know.
Right.
I want this to be confidential. I don't want it to get back. Is that a possibility?
It's not only a possibility, but it's their right as a patient rights issue. We are governed by not only ethical and other types of just kind of moral guidelines and responsibilities, but we have a contract with the state of Oklahoma. We're certified by the state of Oklahoma, and they are very specific about how we honor and stick to the confidentiality of anyone who receives treatment at our facilities. We have to adhere to some very strict guidelines.
Okay. Let's switch in before the break real quick. We'll sort of introduce it and then come back. The disease model of addiction, what is that concept about?
Well, it's in direct contrast to what the model of addiction, what the perception of addiction has been for many, many years. And that's the moral model. Because behaviors of addicts kind of looks like badness.
Right.
And people like to attribute badness to the behavior of alcoholics and other drug addicts. And it was in place for a good reason, because there was no way to identify any other source of the problem. So we'll talk a good deal about where the disease of addiction actually manifests itself.
Okay, so when you say that too, once again before we go to break, when you say that, I think that's really important to get out here. We have often thought, and sometimes still do, that the person is a bad person or they're choosing to do this. It's a choice, and and they can stop whenever they want to. Nobody's making them do that. But that's really more of a fallacy?
It's more of a misconception. It's just a lack of understanding, a lack of knowledge about the true pathology of the disease of addiction.
Okay.
Most people don't even know where it starts. A lot of people know that our vital organs can get damaged heavily and dutifully damaged for someone who's abusing alcohol and other drugs. But the primary organ, which begins the addiction process, not only surprises people, but to the extent and how it all ties in of all the components that are present in a full-blown addict.
Okay.
I believe we can bring some things to light and help people understand.
Okay, and let me ask you one other question before we take our break and get back to this. How young would this model apply? Because we've heard of kids as young as 4 and 5 that have, and of course parents or adults are giving them the drugs, etc., or that type of thing within that environment. But how young would we really look at this model as being really applicable?
Well, we start, as I told you, generally at the age of 12 in assessing adolescents for substance abuse and or addiction issues. So that would be a general viable cutoff, 12. But it doesn't mean that if a younger child who has drank or used themselves or has that greater genetic vulnerability to addiction got there a lot quicker and a lot younger.
Okay, well what we're going to do is take a really quick break and then we'll come back and actually get into this disease model and for you to describe exactly what's happening so that we can get some truth out here.
Great.
Please stay with us. We'll be right back.
Did you know that getting up and getting active for just 60 minutes a day is all it takes to help you get stronger, look better, and feel great?
Or that fresh fruits and veggies aren't just healthier and crunchier, they can taste better too?
Eating better and getting more active is easier than you think.
Yeah! Keep watching for some fun and easy ways to discover the magic of healthy living in your life.
America.
Let's get healthy together!
Welcome back to continue our discussion talking about the disease model of addiction. Joining me again is Brad Collins. He is the program director of the Adolescent Substance Abuse Treatment Center at Palmer Continuum of Care. Let's jump in. Now this disease model of addiction, again, let's start with where did it come from? And then you can sort of help us frame what it's all about. So where did it come from? Who thought of this?
Well, in piecemeal, it's kind of been out there for a long time. I mean, we don't have a great deal of ability to go in and look at the active brain and the addiction process. And I've kind of stolen some of my thunder here because that's where addiction starts.
Okay.
I want to acknowledge Dr. Kevin McCauley at the Institute of Addiction Study. I did so in our first segment that I got to tape with you. And the reason that I acknowledge him and give him credit is because the disease model and the explanation of it that I'm going to share with you all, most of it is his work or an integration of other research that has been put out there for us by Dr. McCauley.
Okay.
So what he did for us, first of all, is let's come up with a workable definition of disease. What does disease mean? What does an illness have to do to get into the disease club?
Okay.
Well, as a doctor, what he explained was there are really 3 components to identifying something as a disease. And that is we have an organ
All right.
that gets a defect, some kind of cellular defect. And from that defect in that organ, you start to see symptoms. And in regard to how that fits with certain things that we're pretty familiar with, for instance, if the pancreas gets an inability, a cellular defect and an inability to create insulin,
We end up with diabetes.
we have diabetes and we start to get the symptoms, which are innumerable
Right.
for diabetes. If we're skiing down a hill and we break our femur, we get the symptoms of a broken leg, all the bleeding and the screaming and all that.
Okay.
But doctors a long time ago, a little over 100 years ago, as a matter of fact, Dr. McCauley says, when they identified the disease model and picked up on the fact that if they stopped chasing the symptoms and they actually went in and fixed the defect of the organ, that healing began. They weren't just chasing symptoms all over the place.
Which is true, and that's sort of like the medical model today, because if you focus only on symptomology, you often don't treat the underlying condition. It's just sort of surface.
Exactly.
So this is that same kind of concept and direction.
Yes, it is.
Okay, so with this, you were talking about the brain.
Correct.
As being the primary focus with addiction.
Yes.
Okay.
And a specific part of the brain.
Okay.
So looking at how the disease of addiction fits into the medical disease model, we had to determine, first of all, where does the disease process begin? And if it's in the brain, what part of the brain? Well, what we know, and there are several resources out there that can give much more detailed explanation of it, because we don't have time to go into it in specific detail. But what occurs is that drugs of abuse, it was thought for years that they affected the frontal cortex of the brain. That's the thinking, reason, decision-making, spiritual part of the brain.
And that's, too, something that we have found that adolescents have, it doesn't mature as quickly. And that makes them prone to making wrong decisions, inaccurate decisions or things like that.
Exactly.
So this frontal cortex,
But the frontal cortex, found out through some research, is not where drugs of abuse administer their effect.
Okay.
It's in a much more primal part of the brain, a much more primitive part of the brain called the midbrain. Included in the midbrain is the pleasure center. And the midbrain serves a very specific survival hierarchy purpose.
Okay.
And it will incite us to eat, to kill, defend ourselves, and to procreate, sex.
Okay.
And those are very basic, below the conscious level instincts.
All right.
Because the disease process begins in the seething unconscious midbrain, and it's below the level of consciousness, once someone is deep into the addiction process, those behaviors that people can't understand why they're doing them, it's because eat, kill, and sex are no longer at the top of the survival hierarchy. the drug of preference has now taken that #1 spot.
Well, let me ask you this, because in that midbrain then, with these particular functions that are there, oftentimes you hear about people who are really abusing substances becoming very promiscuous.
Correct.
And that makes sense now, because that's affecting that particular center, pleasure center.
The pleasure center and the primary neurochemical involved in the pleasure center and drug wanting is dopamine. And that is our pleasure type of neurochemical that if we eat something that's going to sustain our life, we get a little shot of dopamine.
Okay.
If we defend ourselves, not only do we get other types of neurochemicals and hormones going, but we get a little shot of dopamine. Says, good job, you've kept us alive. And naturally in the sex process, we get a shot of dopamine. Says, we're protracting the human life here.
Okay.
Good job, we've done something good.
Okay.
Drugs of abuse create huge surges of dopamine in the midbrain.
Now let me ask this, because some people may be thinking right about now, how do we get this defect? And of course we'll keep talking about it. You did mention a little bit earlier about a genetic connection, because we can think of a car accident of having certain injuries in our body.
Sure.
But if we've never had anything happen to us, then we're saying, okay, how did we become susceptible to this? How did that defect get there? Is it all just genetics? Is it actually the environment, that nature versus nurture kind of thing? What is it?
Well, there's always been that question. Can alcoholics drink themselves into alcoholism, not just be predisposed genetically? Can addicts use themselves into addiction? And the answer unequivocally is yes. And here's why. Genes can be a very important factor in addiction. But here's what we found out. Genetic predisposition does not guarantee addiction. It will generally get the person who's genetically predisposed to addiction faster.
Okay.
You see much more elevated symptoms in someone who has a genetic predisposition, like blackouts, alcohol-induced amnesia, and things of that nature, tolerance on a greater scale, a much quicker scale in people who have a genetic predisposition. But that doesn't guarantee addiction just because someone is genetically predisposed. Because here's another important neurochemical that's involved in the disease process, and it's called CRF. It's corticotropin releasing factor, and it is a stress hormone whose job is to regulate dopamine and keep it at a normal level.
All right.
When we're flooding our brain with dopamine because of the chemicals that we're using, because of drinking, because of using, and corticotropin releasing factor cannot keep the dopamine at that normal level, what's called the hedonic set point, the pleasure homeostasis point. At some point, it says, you know what, to heck with it, let it go. So it gets reset.
At a higher level.
At a higher level. And therefore, it takes more and more dopamine to actually achieve pleasure, to actually feel pleasure.
Okay. Well, we're going to take a really quick break there and come right back and pick up on that, because that makes a lot of sense. And I want to talk about this genetic predisposition. I've got a question.
Sure.
Please stay with us. We'll be right back.
When it's time for lunch, a sandwich is a quick and easy choice. And with the right ingredients, it can be good and good for you. So I'm here today to see who can build the ultimate sandwich. All right, when the time is up, our judges will give you their scores. Ready, set, go! Okay, Jason starts out with a multi-grain roll. Ooh, Allison stuffing her pita with, yes, spinach, a great source of iron. Jason isn't skipping on the protein, adding plenty of smoked turkey, just like Allison's putting the finishing touches with crispy red bell peppers for a dose of vitamin A. Time! It looks like we have a tie. We'll need to call in our special guest referee.
Now, these are what I call quick, delicious lunches. Whole grain breads, a whole variety of ingredients. There are so many different ways to build delicious, healthy sandwiches. These two get high marks in every category. I'd say you're both winners. America.
Let's get healthy together.
Pants, pants, pants. I am folding the pants. Do they go on my head?
Everyday moments can become teaching moments because learning starts long before school does. Give your child the start they need at bornlearning.org.
Up to 40% of businesses never recover after experiencing a major disaster. Make a plan at ready.gov/business.
Welcome back. To complete our discussion talking about the disease model of addiction, joining me again is Brad Collins, Program Director of Adolescent Substance Abuse Treatment Center at Palmer Continuum of Care. Let's jump right in because this is really getting exciting here and very informative. I want to go back to when you were talking about the CRF that is supposed to then help to regulate the dopamine.
Correct.
And when we overloading it with these substances, it says, hold on, I can't do this, so I have to raise this a little bit higher. So you need more substances to achieve the same pleasure that maybe initially you did not need.
Exactly.
And that's why when we look at abusers of alcohol or whatever the drug of choice is, or the substance, in time they're taking more and more and more and more.
Which is called tolerance in the treatment world. Our tolerance builds up, and we need to drink or use more and more to get the desired effect. And isn't really the desired effect pleasure?
Okay. Now with this, let me ask you then about this genetic predisposition. Let's say the person has that kind of predisposition, sure, and they may start drinking wine or little things like that. Are these individuals too that may reach that pleasure high a lot faster? You did talk about how quickly we may reach it. Is it because they're more sensitive to it? Or is it the type of person who says, oh, I can drink a lot or I can take a lot and it doesn't even affect me? I mean, which one is, or is it both?
Well, it really depends upon the person, because that's another one of the confusing things about being able to track and standardize and measure addiction and rate of alcoholism, etc. What we've been able to determine, once again, is that genes are not a guarantee that addiction will occur, that alcoholism will occur. But what we do see, if we have knowledge of a history, a potential genetic predisposition in someone, that we can generally identify that if they start using, if they start drinking, they will reach full-blown addiction much quicker and have that blatant symptomology a lot quicker than someone who may have no genetic predisposition and start to drink or use themselves by changing over a gradual period of time that neurochemical makeup. Okay,
now with this, in terms of that predisposition then, people may want to know, do I know if I'm prone to this by who's been in my family and who's been maybe gone to the point of real addiction, or the people that seem to just drink too much, or the social drinkers, or do I go get a blood test? I mean, how do I know?
Well, and those are great questions, because we want to know how to maybe fend something off before we actually get all caught up in it. However, it's not as scientifically and empirically relevant as a lot of things that we can really measure. What we're talking about more than not is, and this is why we do a complete biopsychosocial and substance abuse and family history. We can determine a lot of the family predisposition by family usage, family of origin, etc. But we also have those folks who, like myself, are adopted and can't really tap into everything that is going to be important in determining if they're going to have a predisposition. But primarily what we look at is in regard to the people that we begin to drink with, or even if it's illicit drugs, if we begin to use with, if our behavior starts to get a little more erratic, if our need to drink or use becomes a little more seemingly dependent than the folks that we have around us, and people are telling us at an early age, you know what, I think you have a drinking problem, or you don't seem to drink or use like we do, you seem to need more, or you seem to never be able to get enough.
Okay.
Those kinds of things are telltale signs that someone may be progressing in toward addiction a lot quicker than their peers.
Yeah, and there are sometimes people that you will see that will tell you, I like to drink. I mean, I just love drinking.
Yeah.
And so you would think that they may have more of this genetic predisposition for that. I mean, they just really have a love for it. And so they need to, of course, look at that a lot sooner and try to get help. Now, let me ask this question then. Okay. So we've got what's happening in the brain here, and so we know it's not where people are intentionally trying to act out or do something, but it's a disease model. How do we begin to change that dynamic, especially in that midbrain? I mean, what do we do? Is that learning how to seek pleasure different? I mean, what do we do? What do we do?
And that's one of the important elements of taking a disease process and taking it back down. One of the things we have to look at real quickly, though, is another neurochemical. It's called glutamate. Dopamine, as I said, is primarily the neurochemical of drug wanting.
Okay.
Glutamate is a memory chemical that says, okay, go get it.
So it's what's helping you remember that that particular thing gave you pleasure.
Gave you pleasure, and then it also starts to remember all the other cues, all the other environmental things, all those, when you hear about someone trying to quit drinking and they can't pass their liquor store without turning in automatically, driving by their old dope dealer's house and getting a drug cue there.
Wow.
Memory is an important part of the continuing to use despite negative consequences.
Right, so this once again becomes like you say, even people that are, to me, cigarettes are a drug.
Well, they are. It's nicotine. It is a drug of abuse, without a doubt.
So people who can't seemingly not smoke when they eat, because it's that glutamine that's helping them to associate the pleasure of the smoking with the eating, and so they continue that vicious cycle because of all of these things that just remind them a trigger. Oh, I need to have this, or I need to have that.
And you can see that when it looks like they're just doing it subconsciously, they it's just an automatic.
Exactly.
It's at a level below consciousness.
Okay.
That's actually where it gets embedded. That's where the motivation comes from. It's not a voluntary thing, and that's why what might look like badness or intentional insensitivity in an addict or an alcoholic is really just them acting upon this subconscious impulse that tells them drinking or using is your first ticket to survival. Okay,
I have about a minute here to get this out of you, Brad. What do we do? How do we control the dopamine? How do we control the CFF to sort of keep things under control? How do we control the glutamine?
Well, the first thing that we have to do, no, we don't primarily take drugs.
Exactly. Some people think, give me another drug, right?
Especially ones that are going to flood the brain with dopamine. But first and foremost, naturally, what we need to do is abstain for a period of time that's going to give our hedonic set point an opportunity to reset itself so we can derive normal pleasure from normally pleasurable things.
Okay.
So that we don't go to Disneyland with our family and they're all having a great time. We're sitting around going, I don't get it.
Right.
We want to be able to restore that. We want to be able to restore the other neurochemicals that are going to give us an opportunity to not feel so restless, so irritable, so discontent, and tap into things that we may have pushed by the wayside that gave us pleasure. Get back into sports, get back into school, get back into our jobs, get back into the relationships that we lost or we've damaged.
Okay, so it's a relearning process.
A relearning and a reinitiation of things that can give us deep meaning.
All right, and that's where therapy helps. Thank you so much for joining me.
You bet.
Well, that's our show. For Health Alert, I'm Pam Butler. I'd love to hear questions, comments, or suggestions for future shows. Please write me at Health Alert USA, P.O. Box 50913, Tulsa, Oklahoma 74150. Health Alert is brought to you by OU Physicians in Tulsa.